Hello friends, let us now learn some important points about anemia. Anemia decreases total circulating red blood cell mass below the normal limits. So if you see, in anemias we have different types of anemia, but in our present chapter we are going to learn some points about hemolytic anemia. Hemolytic anemia occurs due to whenever there is abnormal breakdown of RBC, that abnormal breakdown of RBC results in hemolytic anemia. So if you see features of hemolytic anemia, one, decreased lifespan of RBC, which is due to premature destruction of RBC. Whenever there is premature destruction of RBC, in such cases there is decreased lifespan of RBC. So because of destruction of RBC, the hemoglobin which is left, there will be accumulation of product of hemoglobin catabolism, and because of decreased RBC, that will activate the erythropoietin production from the kidney, which increases the erythropoiesis in the bone marrow. Whenever there is erythropoiesis in the bone marrow increases, the precursors, that means mothers of RBCs, like increased reticulocyte count is seen. Now let us learn about the classification of hemolytic anemia. Hemolytic anemias can be classified to be intravascular hemolysis and extravascular hemolysis. In intravascular hemolysis, RBC breakdown occurs in blood vessels. Whenever the that is inside the vascular blood vessels, so breakdown of RBC occurs in the blood vessels. In such cases, there is release of hemoglobin in the blood occurs. So there is increased hemoglobin in the blood is seen, which is called as hemoglobinemia. And there is increased hemoglobin which will reach the kidney also, and the hemoglobin is filtered into the urine, causing hemoglobinuria, and some hemoglobin is absorbed in the kidney, and this hemoglobin which is absorbed in the kidney gets converted to hemosiderin, and this is excreted. This results in hemosideриnuria, right, because the hemoglobin is excreted, resulting in hemosideриnuria. There is increased free hemoglobin. The increased free hemoglobin combines with haptoglobin and it forms a complex which is cleared by mononuclear phagocytic cells. So this complex, because this complex is cleared, so at the end, along with this complex, even the haptoglobin is lost. So we will see decreased haptoglobin level is seen because of the complex is lost. Then if there is biliary obstruction, this will mask the low haptoglobin levels. So sometimes there are chances where there can be increased haptoglobin level in the patient. So if the haptoglobin is depleted, okay, now haptoglobin is depleted, we have free hemoglobin. This free hemoglobin is oxidized to methemoglobin, thus resulting in methemoglobinemia. This methemoglobinemia is one of the characteristic feature of intravascular hemolysis. Then heme group also gets degraded. So this once heme is degraded, hemoglobin will undergo catabolism and it forms bilirubin in the mononuclear cells, which increases the formation of jaundice and indirect bilirubin. Next, LDH is normally stored in the blood, but whenever there is hemolysis, this LDH which is stored in the cells is released inside the blood, thus increasing the serum LDH level. So these are all the features of intravascular hemolysis. The examples of intravascular hemolysis include paroxysmal nocturnal hemoglobinuria, G6PD deficiency, Clostridial toxin, falciparum, malaria, or mechanical injury to RBC, which include defective cardiac valves or thrombin microcirculation. Defective cardiac valves and thrombin microcirculation, and it also includes sickle cell anemia. So these are the intravascular hemolytic anemias examples. Now, if you see in extravascular hemoglobin hemolytic anemia, the RBC breakdown occurs, but this breakdown occurs in mononuclear phagocytic system of spleen, liver and bone marrow. That is, it does not occur in the blood vessels, but instead it occurs in spleen, liver and bone marrow. Because, so as a result, hemoglobin is not released in blood. So there is no hemoglobinemia, there is no hemoglobinuria, there is no hemosideruria, or there is no methemoglobinemia like that we have seen in intravascular hemolysis. So here hemoglobin gets converted to heme, which gets converted to bilirubin. This bilirubin leads to the formation of jaundice. Then whenever because the breakdown occurs in the spleen or mononuclear phagocytic system, we see enlargement and hyperplasia of those mononuclear phagocytic system is seen, leading to increased splenomegaly. There is also increased urinary urobilinogen levels are seen, and there is increased fecal stercobilinogen levels are also seen here. If you see the examples of extravascular hemolysis, the examples of extravascular hemolysis includes, we have hereditary spherocytosis, sickle cell, this include hereditary spherocytosis, sickle cell anemia, thalassemia, autoimmune hemolytic anemia, then drug-induced hemolytic anemia, G6PD deficiency. If you see, glucose 6-phosphate dehydrogenase deficiency is a part of both intravascular and extravascular hemolysis. Then we will see the differences between hemolytic anemia can again be divided into two types. One, we have intracapsular hemolytic anemia. Second, we have extracapsular hemolytic anemia. In intracapsular hemolytic anemia, the cause of hemolysis is intrinsic to RBC. So example is here, the problem of hemolysis is due to the defect in the RBC. Like for example, in sickle cell anemia, there are sickled RBCs which are destroyed. In thalassemia, there is problem in alpha, defect in alpha and beta chains, and thus destroyed. In hereditary spherocytosis, there is a defect in RBC membrane protein ankyrin or spectrin. In G6PD deficiency, there is defect in the enzyme. In paroxysmal nocturnal hemoglobinuria also, there is defect in RBC. In extracapsular hemolytic anemia, the cause of hemolysis is not within the RBC. So if you see the examples, it is immune hemolytic anemia. Then we have microangiopathic. This includes microangiopathic hemolytic anemia, which include thrombotic thrombocytopenic purpura, hemolytic uremic syndrome, and disseminated intravascular coagulation. It also includes malaria, prosthetic valves, and it includes hypersplenism. So these are the two causes of hemolytic anemia. Then let us now learn some important points about osmotic fragility of RBC. In osmotic fragility of RBC, there is increased resistance of RBC hemolytic to osmotic changes. So, for example, we will learn about it clearly. For example, if normally RBCs maintain osmotic equilibrium with serum. That means if you put the RBCs in a container filled with serum, then RBCs will be completely normal. But if you put the same RBCs in hypotonic fluid, that means the surrounding fluid has less osmolarity when compared to the RBC. So as a result, there will be movement of fluid or water from the extracellular environment into the RBC. Then the RBC swells up and then the RBC ruptures, leading to osmotic lysis. Osmotic fragility osmotic fragility will measure the degree of hemolysis that RBC can undergo in a hypotonic fluid. So if you see, normal RBC begin to lyse at around 0.5% of normal saline NaCl. If you just add 0.5% of NaCl, normal RBC will begin to lyse and it completely lyses by 0.3% NaCl. There are some conditions where osmotic fragility increases. We can say osmotic fragility increases if hemolysis of RBC occurs in sodium chloride of more than 0.5% concentration. And we can also, that means that concentration is more than 0.5, then the osmotic fragility increases. Osmotic fragility is said to be decreased if hemolysis does not occur in 0.3% NaCl. That means it requires even more concentration to complete hemolysis. So the examples of increased osmolarity, osmotic fragility and decreased osmotic fragility is important. Conditions where we see increased osmotic fragility include hereditary spherocytosis, hemolytic anemia, that is acquired immune hemolytic anemia, malaria, severe pyruvate kinase deficiency, and also hemolytic disease of newborn. Then the diseases which decrease osmotic fragility are iron deficiency anemia, thalassemia, liver disease, reticulocytosis, hemoglobinopathies like HBS and HBC. So these are the conditions where you see increased osmotic fragility and decreased osmotic fragility. Thank you for watching.